Hi, good afternoon, everyone. Grand rounds is a long-standing methodology in medical education where doctors, residents, students gather and they learn a lot. So this is the purpose of Learn Simply Academy, to have grand rounds for education, clinical discussion, professional development, and community building. Since we organize and speak on the grand rounds, and we are really happy that lot many good mentors have already given their consent, and we are doing these sessions regularly. So today I am really very happy to have Dr. Neerja Bhatla, gynecologist of the country. At present, we all know she is a Padma Shri awardee, and at present she is a director of AIMS Bhatinda. But what she has done, she has spent over 3 decades working on a cervical cancer prevention, especially in the low resource setting, and led the 2018 revision of FIGO cervical cancer staging guidelines. To her contribution to the women's healthcare, she was conferred the Padma Shri in 2025. Among other honors, including Dr. S.K. Ghai Bhandari Award and ISCP Excellence Award from the Indian Society of Colposcopy and Cervical Pathology. But the best part, she's such a dedicated and very important person. So welcome, Dr. Neerja.
Hello, dear friends. It is a pleasure to be here today on the Learn Simply platform. And I bring you greetings on this occasion. And I am going to share my slides with you now. Today, I am going to be talking on the topic of maternal anemia and fetal programming. And I will be happy to join you for a live question-answer session at the end. So very thanks to Dr. Kawita Bapat, who has set up this whole platform and makes it easy to learn. And I hope you are going to find this session very useful. Briefly, we will go through what is the global burden and epidemiology of maternal anemia, the core concepts of fetal programming, maternal anemia impact on fetal oxygen delivery and effects on development of various fetal organ systems, the long-term outcomes, and some of our supplementation programs. Now, we know that about 40% of pregnant women are affected globally, which means there are about 32 million worldwide. More than 50% of these are cases of iron deficiency anemia. And in South Asia and Sub-Saharan Africa, we have 2 to 3 times the burden elsewhere. Now, the pathophysiology and classification of anemia in pregnancy has been well worked out. We go by the WHO definition that hemoglobin less than 11 grams in the first and third trimesters or less than 10.5 in the second trimester. And broadly, we categorize as iron deficiency anemia, which is 50 to 70% of the cases, basically a reduced hemoglobin synthesis. Then we have folate and B12 deficiency. We find megaloblastic anemia. There are real risks of neural tube defects in the baby here. Then the hemoglobinopathy, sickle cell anemia, thalassemia, and also hemolysis. Infectious causes like malaria and HIV, we still have endemic regions, and we have to focus here on the destruction of the parasites apart from treating the mother. The physiologic anemia of pregnancy, of course, we know that there's a normal plasma expansion, there's a hemoglobin dilution. And chronic inflammation, anemia of chronic disease, and we know here that there is a rise of hepcidin in such cases. Now, iron deficiency anemia is the most common cause, and we see it manifest in 3 stages. In the first, when the iron is depleted, the hemoglobin may be normal, but the ferritin is low. In stage 2, when there is iron deficient erythropoiesis, there will be an increase in the total iron binding capacity and a decrease in the transferrin saturations. And the third stage is the frank iron deficiency anemia, where the hemoglobin is low and you have microcytic hypochromic RBCs. So there are many ways why pregnancy will increase the iron demand. The maternal RBC mass itself is increased about 450 ml, so it needs about 500 milligrams of iron. The fetoplacental unit requires about 300 milligrams. There's a total extra demand of about 800,000 milligrams over the course of pregnancy. This translates into a basal requirement of 1.8 milligram per day in the non-pregnant state, increasing to 7.5 milligram per day by the third trimester. And dietary absorption is often insufficient if there is no supplementation. So while this maternal anemia is a global public health burden during pregnancy, we have to worry about how it impairs the fetal placental perfusion, leading to fetal hypoxia that disrupts vital physiological and biochemical pathways. This affects fetal growth and developmental programming, resulting in adverse perinatal outcomes and susceptibility to various NCDs later in life. The core concept started really with the Barker hypothesis. He spoke about the developmental origins of health and disease, acronymed as DOHAD. These adverse intrauterine environments, he showed, can permanently alter the fetal structure, physiology, and metabolism, predisposing to chronic disease in later life. And the sensitive windows are the periods of organogenesis, 3rd to 8th week of gestation, and the rapid growth phases, which are most vulnerable. There are adaptive responses where the fetus prioritizes the vital organs, the brain, heart, at the cost of the others, and has the thrifty phenotype. So you have the predictive adaptive response where the fetus predicts the postnatal environment from the intrauterine cues, and the mismatch causes the risk of disease. But you also have the problem of epigenetic imprinting, where the nutrient availability alters the DNA methylation, histone modification, microRNA expression, leading to transgenerational effects. These program changes can be inherited across generations via germline epigenetics. And the critical periods are the first 1,000 days, that is conception to 2 years, which represent the primary programming window and which is currently the focus of all maternal health and neonatal health programs. So this is the Barker hypothesis. He took the national sample of 9,921 10-year-olds and 3,259 adults in Britain. He found that the systolic BP was inversely related to the birth weight, the low birth weight associated with increased risk of coronary artery disease, hypertension, type 2 diabetes. And he showed thereby that the maternal undernutrition and anemia contribute to FGR and low birth weight, forming the basis of fetal programming. The Dutch famine of 1944-1945 is also well known. It's also known as the Hunger Winter. It was a famine in the German-occupied Netherlands during World War II. They found that exposure to maternal malnutrition during pregnancy resulted in offspring with obesity, diabetes, cardiovascular disease, and altered DNA methylation was found even decades later and even in the subsequent second and third generations, making it one of the strongest human proofs of developmental programming. And there are several YouTube videos which are available, and I can recommend this one to watch and see how these things played out. So the maternal hemoglobin decrease affects the oxygen carrying capacity, causes a compensatory increase in the heart rate and the cardiac output, and decreases the uteroplacental perfusion. The fetal consequences include IUGR, brain sparing effects, polycythemia, preterm birth, stillbirth risk, and metabolic reprogramming. The effects on the placental development and function are also important because the placenta is both a target and a mediator of maternal anemia effects on fetal programming. So you find changes in the morphology like placentomegaly, increased placental birth weight to birth weight ratio, the villus trophoblast hypertrophy, abnormal vascular branching, decreased intervillus space volume, the molecular adaptations, increase in the angiogenic factor upregulations, increase in the VEGF and PLGF, increase in the glucose transporter expression, altered iron transport, and endocrine disruption. Decrease in the placental lactogen release results in insulin resistance, altered secretion in the corticotrophin releasing hormone, glucocorticoid metabolism changes, increased cortisol exposure alters the programming of the HPA. The inflammatory milieu also is no less. There's an increase in IL-6, TNF-alpha, oxidative stress as evidenced by decrease in the INSOD and the glutathione peroxidase, and the activation of the NF-κB pathways and altered innate immune programming of the fetus. So iron has now been shown to be critical for myelination, neurotransmitter synthesis, hippocampal development, and mitochondrial energy production. So these direct actions of the iron on the neurodevelopment is very important and a great concern. The hippocampus will decrease in volume, altering the memory and learning defects. The myelination will be delayed, resulting in slower conduction velocity. The monoamine systems will be impacted, causing mood and anxiety programming. The striatum and dopamine transporter effects will manifest in attention, motor, and behavioral deficits. And the auditory system will be altered, leading to altered brainstem auditory evoked potentials, which can be a marker of iron deficiency anemia in infants. And the energy metabolism is also affected in the neurons and impaired oxidative phosphorylation. So there are some studies which have come out, like this one from southwestern Uganda, which looked at the anemic women and looked at their uterine artery flow resistance and found that it was increased with a lower cerebral placental ratio, and this corresponded with the severity of the anemia and had potential implications on fetal cardiovascular health. There was this one which has shown that the maternal anemia will affect the fetal neurodevelopment. A very good analysis from the Stockholm Youth Cohort found that when they looked at the outcomes like the ASD, ADHD, or ID, they found that these were significantly higher. The autism spectrum disorders, the attention deficit syndromes, the intellectual disability were all seen to be impacted more in the first 30 weeks of pregnancy compared with those who developed anemia later in pregnancy or those who did not have anemia at all. And this was done after controlling for socioeconomic, maternal, and pregnancy-related factors. So this shows that it is very, very important to start pregnancy in a very good shape, to have the preconception counseling and make sure that they are not anemic at the start of pregnancy, because we do need the iron for myelination, dendrite arborization, synthesis of the monoamine neurotransmitters. It's a long list of mechanisms that do impact the fetal development, and these cannot be made up in the post-delivery phases. The cardiovascular and metabolic programming also has been shown. The cardiac remodeling, the HPA axis programming, insulin resistance, adipose tissue distribution, lipid metabolism, vascular tone. And the epigenetic mechanisms of fetal programming have shown that they can be manifested through the DNA methylation, through the histone modification, through the microRNA factors, and the telomere biology. And you know that the telomeres are a marker of age and aging. And this has been shown that the oxidative stress from iron deficiency shortens the telomeres in fetal cells. And this at birth is associated with accelerated aging, CVD, and cancer risk in later life. Neonatal and infant outcomes, of course, we know that the anthropometric parameters like the birth weight, SGA, reduced head circumference, reduced skin fold thickness, and the immediate neonatal NICU admissions, neonatal iron deficiency, polycythemia, hypothermia susceptibility, because there's a decrease in the brown adipose tissue. And then the neurobehavioral, which we talked about, but also the sleep state organization, habituation responses, visual ego potentials, and their immunological parameters. There's a reduced transfer of passive immunity, altered thymic development, decreased natural killer cell activity and T cell proliferation, and increased susceptibility to neonatal infections. And then the long-term child health outcomes, the neurodevelopment and metabolic factors. So there is a delay in infancy in the psychomotor milestones, increased fearfulness, altered temperament. In toddlers, there are language delays and reduced social interaction, altered play behavior, neurobehavioral immaturity. And then in the 5 to 12 school age, there you can see lower IQs, reduced academic achievement, increased ADHD and motor coordination difficulties. And in adolescence, there's a persistent cognitive disadvantage, increased anxiety and depressive symptoms, altered metabolic parameters, reduced physical work capacity. So diagnosis and screening in pregnancy, of course, I'm sure you are all familiar with, but you can use this chart as a ready reckoner, and you can see that what is the threshold, what is the use of this test, and what are the limitations. And hemoglobin, of course, that we know it, but it's a late marker. Serum ferritin is a gold standard for the iron stores, but it is also an acute phase reactant and falsely elevated in inflammation. Serum iron in TIBC we don't use alone, but it confirms IDA when the ferritin is ambiguous. The transferrin saturation is a stage 2 indicator. Reticulocyte hemoglobin is not widely available. The peripheral blood film is a very easy to do one, but it is a little subjective and observer dependent. The serum hepcidin is an emerging biomarker which distinguishes the ACD from IDA, but not standardized clinically yet. So the iron supplementation, the daily oral iron, 30 to 60 milligram elemental iron, we definitely use 60. The intermittent oral iron can be done, which is good when not tolerated. And we did many studies on this as well. And we found that women who are non-anemic at the start, you can definitely do the intermittent oral and they will maintain their hemoglobin. But if they are anemic, then there is no way that they are going to maintain their, to be able to build up their hemoglobin. And IV iron is par for the course now because it is a very safe product, and giving 1,000 milligram single dose in the second or third trimester can be done. It's a superior hemoglobin recovery in moderate to severe. The preferred trial showed it is non-inferior to daily oral and fewer GI effects. But what is the new thing now is the MMS, the multiple micronutrient supplementation. And it is being seen that giving iron alone is not as beneficial as prescribing along with the others. And the WHO formulation for this contains the 15 nutrients, including, of course, iron and folate. But this has been found to be more useful in preventing the LBW and the small for gestation age. So these other nutritional and non-iron interventions include the folic acid, of course, but the vitamin B12, especially among vegetarians and vegans, and it has independently also been linked to NTDs and neurodevelopmental outcomes. Vitamin C, which we know enhances the iron absorption. Vitamin A, which is synergistic with iron and hemoglobin synthesis. Zinc, which competes with iron for separate timing, is recommended, but essential for cell division, growth, hormone signaling, and immune function, and its deficiency compounds the growth restriction. Malaria prophylaxis is a must in the endemic areas, and intermittent preventive treatment with sulfadoxine pyrimethamine reduces the malaria-related anemia and placental malaria and improves the birth outcomes significantly in high transmission areas. So you know the clinical management protocols, and I think I will add one thing over here which is not mentioned is the deworming, which is very important, a standard dose of 400 milligram albendazole. But apart from that, you can give the oral iron in the mild anemias, dietary counseling, and do the reticulocyte count at 2 to 4 weeks, the ferritin recheck at 4 to 8 weeks, and fetal growth scans at 28, 32, and 36 weeks. The moderate anemia, you can increase to 120 milligrams a day and BID if tolerated, or consider IV iron if oral is not tolerated. Close fetal surveillance and maternal cardiac assessment is important. And in the severe anemia, IV iron or blood transfusion, hospitalization if symptomatic, daily fetal monitoring, and require multidisciplinary treatment by the obstetrician, hematologist, and neonatologist. And if it is persistent, you may consider an early delivery. So prevention strategies across the life course start really from preconception. And in FOXI, it has been strongly recommended. It's being talked about by the national level, by the ministry also. And screening and treating anemia before pregnancy, starting the iron and folate supplementation preconceptionally, treating the hookworm parasites, optimizing the iron stores to have a ferritin over 30. And then in the first trimester, universal hemoglobin and ferritin at booking visit, start the iron folic acid supplementation, usually folic acid only in the first trimester. But dietary counseling, iron-rich foods, avoid tea, coffee,